Bismillah ar-Rahman ar-Rahim. I'll be talking about the esophagus. The esophagus extends from the cricoid cartilage at level of C6 to the hiatus in the diaphragm at level of T10. It is 25 centimeter long. It has three parts, cervical, thoracic, and abdominal. The last few centimeters of the esophagus is within the intraperitoneal cavity. It has an upper sphincter, which is a real anatomical sphincter, the cricopharyngeus muscle, while the lower esophagus is not a real anatomical sphincter, but a high pressure zone. It is the last 3 to 5 centimeters of the esophagus, which lies in this high pressure zone, which acts as a functional sphincter. It is held loosely in the hiatus by the phrenoesophageal ligament. The mucosa of the esophagus is squamous epithelium mainly, and the muscular layer has two muscles, inner circular and outer longitudinal. The upper third is striated muscle, which means it's voluntary. We start our swallowing voluntarily, while the rest of the esophagus is smooth muscle. The remainder is smooth muscle, which is involuntary. Once the deglutition starts voluntarily, it continues involuntarily. Between the muscular layer and the mucosa, there is the submucosa, in which runs the mucus glands and the lymphatics. The blood supply, the upper cervical part of the esophagus by the inferior thyroid artery, the thoracic part by branches from the thoracic aorta and the thorax, and the lower part by the inferior phrenic and left gastric arteries in the abdominal part. Along the arterial supply runs the venous drainage, the inferior thyroid vein in the neck, the upper thyroid, the upper esophagus, and the hemiazygous and azygous vein in the thorax, and in the abdomen, the small abdominal part by the left gastric vein, which drains into the portal circulation. So the lower esophagus is one of the areas where there is a portosystemic anastomosis, and it's a source of bleeding in case of portal hypertension, where the esophageal varices develop and bleed. Sympathetic nerve supply from T5 and T6, and postganglionic from the cervical, vertebral, and celiac, cervical, vertebral, and celiac ganglion. The parasympathetic nerve supply by glossopharyngeal, recurrent laryngeal, and vagus nerve. Vagus nerve is the most important nerve in the enteric nerve supply of the GIT. Lymphatics run in the submucosa to the regional lymph nodes, and then the posterior mediastinal, supraclavicular, and celiac lymph nodes. The peristalsis of the esophagus is initiated by swallowing, which is the primary peristalsis, or by luminal distension, the secondary one. Starts primary and then continues secondary. It runs at a rate of 2 to 4 centimeters per second. It requires coordinated contraction of the muscle of the esophagus and relaxation of the lower esophageal sphincter. The lower esophageal sphincter relaxes 2 to 3 seconds before the wave arrives, and with this peristalsis, it reaches an intraluminal pressure of 80 millimeter mercury. Remember this number because in some pathological conditions, it can reach double this pressure. This coordinated process of deglutition of swallowing, if it is disturbed at any stage of this process, it will end with difficulties in swallowing or painful swallowing. The nerve supply, the Auerbach or myenteric plexus, runs between the two muscular layers, the inner circular and the outer longitudinal. And the Meissner submucosal plexus is the sensory nerve supply of the esophagus. Both the myenteric and Meissner plexus makes part of the enteric nervous system of the GIT. The salivary glands secrete about 1 liter of alkaline saliva, which runs into the esophagus and helps to lubricate the eaten fluid and also neutralize any reflux gastric acid from the stomach. Dysphagia. Dysphagia is the most important symptom of the esophagus, and it is a serious symptom. It should never be neglected. It should be taken seriously. Every time you find a patient with dysphagia, you should take it very seriously and investigate it to the end. Dysphagia is feeling of obstruction to swallowing. The onset varies according to the pathology causing this dysphagia. The sudden dysphagia is most probably caused by a foreign body. No pathology can develop suddenly. In carcinoma of the esophagus, it develops relatively quickly over some weeks, while benign diseases over years. The site is poorly related to the real site of pathology. Most of the patients cannot define the site of the pathology according to the pathology, the real pathological site. The progression in stricture, it is progressive. Every time it's worse than the time before. While in functional disorders, it's intermittent. Sometimes he has the difficulty, sometimes he is okay, until the disease progresses. The severity and type of difficulty of swallowing also differs between different pathologies. In carcinoma, it starts with solid food and then progress to, at the end, to fluids, while in functional obstruction of achalasia, for example, it starts difficulty in swallowing both fluids and solids from the beginning. This is the different pathologies according to the site of obstruction, the site of pathology. Odynophagia is painful swallowing. Usually it's associated with esophagitis, inflammation of the esophagus, or spasm. Sometimes the spasm is painful in the esophagus. It can be due to mechanical obstruction or functional disorder. Heartburn is erythrosternal pain, which is usually experienced in cases of gastroesophageal reflux disease. Dyspepsia is a combined combination of difficulties on eating. It is not a specific symptom like others, but it is describing all difficulties after eating food, what's called عسر هضم بالعربية. pain, belching, heartburn, nausea, early satiety, all together is dyspepsia, difficulty after eating. These symptoms are quite common, and we should try to sort out which is indicating serious condition to investigate more, and which can be treated empirically simply by the GP clinic. The recommendations is to treat these symptoms empirically, symptomatically, as long as there are no alarming symptoms and as long as the patient is responding to your treatment. If the patient is not responding, or we have one of these serious, what is called alarming symptoms, we should refer this patient to endoscopy without waiting. Some of them are quite clear: the epigastric mass, the vomiting, obstruction. The ones which were paying attention to them is the anemia and bleeding and loss of weight. If you have a patient with loss of weight, unintentional loss of weight, or anemia, investigate. Regurgitation and vomiting. Regurgitation is an effortless process. The food regurgitates into the mouth. It's found in functional disorders like achalasia and GERD, reflux disease. Vomiting is an active process which is caused by a forceful contraction of the abdominal muscles while relaxation of the lower esophageal sphincter. And it has many reasons. On examination, we finished with the symptoms of the esophagus. Now we come to examination. Always go systemically. The clinical process has three arms: history, physical examination, and investigation. So go systemic in your approach always. These are general signs which can be found in iron deficiency anemia, which can draw your attention to the pathology. Smooth tongue, pallor, koilonychia are signs of iron deficiency anemia. Lymphadenopathy should be also noticed, and some signs of metastatic disease. Unfortunately, when we find these symptoms, the patient is too late. But we have to pay attention to these symptoms, to these signs of metastatic disease. Lymphadenopathy and the famous Vercau's nodes in the left supraclavicular fossa, which causes Trozier sign. It's Vercau's node, but Trozier sign. Hepatomegaly might reflect liver metastasis, any mass, ascites, weight loss. Sister Joseph nodule is famous, but it's uncommonly seen. It's metastatic deposit in the umbilicus. Investigating the esophagus patients, CBC, to show any anemia or infection, any leukocytosis. Urea and electrolytes are important in cases of vomiting, and also pay attention to the potassium always, because it's very common in this repeated vomiting to have hypokalemia and hyponatremia. Always adjust the electrolytes. Liver function test, low plasma protein, abnormal clotting. Remember that the clotting is a liver function. Any patient with liver dysfunction will have problems with clotting, and this is important in cases of surgery. and cases of hypertension, portal hypertension. The chest X-ray, it may show results of repeated aspiration and pneumonia, and it may show air fluid levels behind the heart, which might reflect a herniated stomach into the chest. This is the mediastinal emphysema. In cases of perforation of the esophagus, you will see a rim of air in the mediastinum, and sometimes, and the neck also can extend to the neck, and sometimes we can see hemopneumothorax. It perforates into the pleural cavity. The contrast study, we rarely do now isolated contrast studies. We do it as a part of CT scan with contrast. It will show this narrowing with dilatation of the esophagus above the narrowing, this rat tail appearance, which is a frank picture of cancer esophagus. Also, the contrast study might show a paraesophageal hernia, hiatus hernia. Here we can see a paraesophageal hiatus hernia. Endoscopy, of course, it is the gold standard of diagnosing esophageal disease. Usually, we go in the first line to the endoscopy. And it gives you the chance also to take a biopsy to have a histological diagnosis. Some endoscopic, also therapeutic procedures can be performed, like dilatation of strictures or injection of bleeding paresis. CT can help us in assessing the picture of metastatic disease. Also, it shows you an anatomical picture of the pathology, even if it is diagnosed by endoscopy. Staging also uses other modalities, as we will see now. The endoscopic ultrasound is very helpful to assess the exact penetration of the esophageal tumor. It's very good to assess the T and N components of T&M staging. It will show the tumor. In the upper picture, you can see a limited small tumor confined to the mucosa, while in the lower one you can see a big tumor which with complete destruction of all layers of the esophagus. Staging laparoscopy is the last modality. When it is done, it can detect sometimes a small metastasis which cannot be detected by the imaging. So by staging laparoscopy, we can additionally exclude more patients from curative treatment. About 20% more of patients will be upstaged by this modality, and then surgery can be avoided. PET scan is another modality, nuclear scan, to detect distant metastases using a radio-labeled glucose analog, FDG. These are advanced investigations, manometry and pH studies by inserting intraluminal electrode with a tube, with something like NG tube, placed 5 centimeters above the gastroesophageal junction, and detects, measures the pH there over a period, and correlates these measurements with the patient's symptoms to diagnose GERD disease or other functional disorders. Also, manometry can help to diagnose the functional disorders of the esophagus by measuring the intraluminal pressure and monitoring it. Management. Management of GERD disease. As we said, we can initially treat them empirically, symptomatically, because these symptoms are very, very common. Up to 30% of the population might have GERD symptoms at one time. So we cannot investigate all these patients. We cannot send all of them to endoscopy, upper GI endoscopy. So we start empirical treatment with proton pump inhibitors and then monitor the response of the patients and look for the alarming symptoms we mentioned before. If they are responding, well and good. If they are not responding, or we are facing one of these alarming symptoms, then we should refer them to upper GI endoscopy. Barrett's esophagus is considered a pre-malignant condition, so it's worth attention and follow-up. It's a histological diagnosis, not clinical diagnosis. The histology, the biopsies we take from the inflamed, pathological looking esophagus, we take biopsy, and then the histopathology will show a metaplasia. What was the meaning of metaplasia? Change from one type of tissue to another type. Here the change is from squamous epithelium to columnar type. The squamous epithelium cannot tolerate acid, so repeated acid exposure with GERD disease will cause this metaplasia to columnar epithelium. These cases should be closely followed up, because sometimes after this metaplasia there will be dysplasia. Dysplasia is change of the tissue histology to irregular histology, which has grades, low grade and high grade. And the monitoring of these lesions with biopsies and histopathological examination will lead us to the management of these cases. The incidence of this condition is increasing, probably because of the GERD disease, and this is a target group for surveillance and close observation to detect any early neoplasia. It can be eradicated by radiofrequency ablation or by mucosal resection. The surgical treatment of reflux disease is available, and now it is done in most cases laparoscopically. So it is indicated when the symptoms are not controlled by conservative treatment, or we face one of the complications. So if the condition, GERD disease, is not responding to your conservative treatment, or one of the complications started to appear, then you have to consider surgery. What are the complications? One of them is this Barrett's metaplasia, esophagitis, which can progress to ulceration, and this ulceration can progress to stricture. We shouldn't wait for stricture formation. Anti-reflux surgery. The anti-reflux surgery has two parts. If there's a hiatus hernia, which means the hiatus is big, we have to take some sutures to reduce the hiatus opening. After reduction, of course. First we reduce, we pull down the herniated part, and then we decrease this opening by few sutures between the two crura, the right crus and left crus, to make it more tight. After that, we mobilize the fundus of the esophagus. صحي اللي جنبك صاحبتك النايمة. Then we mobilize the fundus of the stomach and wrap it around the lower part of the esophagus to make a wrap. This is the fundoplication. It has many forms. The most well-known is Nissen fundoplication, which is a complete wrap, 360 degrees wrap. We wrap all around the lower esophagus and suture it to the left side of the fundus. The other procedures, like of partial fundoplication, like toupee, it's a posterior 270 degrees wrap, and the Watson anterior 180 degrees wrap. There are no significant difference in the long-term results between these different types of fundoplication, but the early dysphagia, which sometimes experienced, is more common in the complete wrap. Most of the surgeons are doing Nissen fundoplication, complete 360 degrees wrap. The response is good. 90% improvement at 1 year, but it decreased with time to 70 to 80% at 10 years from operation. The complication, early dysphagia, which improves most of the time, it improves. رايحين نهائيا ولا إجازة صغيرة؟ لأنه بدنا نعمل تفقد آخر المحاضرة. Unwanted complications, the main complication is the gas bloat, which is inability to belch. يعني المريض ما بيقدر يتجشأ بعد Nissen fundoplication, which can be very distressing if he takes a carbonated drink. This is why we warn these patients not to take carbonated drinks at all. This is the first part, the reduction and the decrease of the size of the hiatus. And then this is the wrap. We mobilize the fundus and wrap it around the lower esophagus. So in summary, these patients should be approached, gradual approach. Advise them to change the lifestyle to decrease smoking, obesity, reduce the obesity, and the most important is not to take food just before going to bed. I tell my patients to have their last meal 4 hours before going to bed. If they are going to bed at 12 o'clock, no food at 8 o'clock. This is the most important advice you offer to these patients with GERD disease. PPI is the main treatment. We generally improve them quite well. The long-standing disease is at risk of developing Barrett's esophagus, so they should be screened and followed up closely. Anti-reflux surgery is available and cost-effective and has good results. Hiatus hernia, the importance of hiatus hernia is the result of GERD disease, the reflux. So we treat reflux, we don't treat hiatus hernia. If somebody has hiatus hernia without reflux, we leave him alone. If somebody has reflux without hiatus hernia, we might consider surgery. So the important thing is the reflux disease, not the hiatus hernia by itself. But usually, the big hiatus hernia will result in GERD disease. There is abnormal protrusion of the stomach through the esophageal diaphragmatic hiatus into the thorax. If the whole stomach slides up with the gastroesophageal junction becomes in the thorax, this is called sliding hernia. If part of the stomach slides beside the gastroesophageal junction, the fundus herniates beside the esophagus, it is called rolling hernia. The rolling hernia is the dangerous one because it might strangulate. So usually it's considered as an emergency condition.